What if I told you that something as common as leaking when you laugh, pain with intimacy, or constant urgency to run to the bathroom isn't just part of getting older or what happens after kids, but it's actually signs of pelvic floor dysfunction? And more importantly, that you can do something about it. I'm Cathy O'Brien, and this is Inside the Wellspace. Today, I'm joined by Kate Fishman, senior physical therapist at New York Presbyterian Weill Cornell Medical Center, who specializes in pelvic health. Kate combines cutting-edge physical therapy with a holistic, whole-person approach to help people take back control of their bodies and their confidence. In this conversation, we'll talk about what pelvic floor dysfunction really is, why it's so incredibly common, and how physical therapy can be life-changing in treating issues like incontinence, pelvic pain, and sexual dysfunction. And most importantly, you'll learn that you have the power to change it. So let's get inside the Wellspace with Kate Fishman. So, hi.
Hello, it's an honor to be here.
I am so happy to be here with you. You have so much to say to us, which I'm really excited. But yes. I think the first thing I said to you was I was away at a 60th birthday party for a dear friend of mine, bunch of girls, like between, 40 and 60 and change.
Yes.
I was the only person there that was not talking about this. So I felt like, lucky for now, clock is ticking.
It's good to get ahead of it.
It's good to get ahead of it. So, we have a lot to talk about and you have some show and tell materials, which people are really excited about. So I'm going to just stop talking for the moment. And would you mind just kicking us off by just giving us a brief history of you and how you got started in this world, this very important world, and then we'll get into it.
Of course.
Thank you.
So again, thank you so much for having me and just spreading the word. I'm Kate. I'm a physical therapist, now a senior PT, and I started in the world of pelvic health back in grad school. So I went to Columbia University for physical therapy school.
I went there for social work.
There we go.
Look at us, twins.
That's why we get along.
This is why we get along.
We had a few different electives, and I chose one of the pelvic health electives.
Is that because that just was interesting to you, or it was a gut course? Like what?
I think it was a gut feeling of, hey, I find that interesting. My mom and I always joke around about pelvic things at home. Okay. So perhaps part of it is the upbringing and her openness to it, which I'm so grateful for.
Oh, I love that.
'Cause I recognize that's not true for everyone. And I really need to honor that with my clients.
I'm so glad you said that. What, the open relationship that you have?
And talking about things that are taboo in other households.
Amen. Yeah. That's so right. That's so right. I have a very close relationship with both of my kids. We talk about pretty much everything. So I appreciate that you say that out loud, because it is important to just talk about things that are uncomfortable.
For sure.
Yeah.
That's how we normalize things.
Yeah.
So yes, I took the elective. I fell in love with it. I actually created a clinical with the person teaching it because I wanted to get into it earlier.
Oh.
I just started taking courses, and the more you learn, the more you recognize how much you don't know. So,
oh God. And like every day of my life, Jesus.
Yeah.
Uh-huh. So that's you just kept learning.
Yes. Absolutely.
Really, really beautiful. And then you landed at one of the, if not the best, hospital in the city. So how did that happen? And tell us about your practice and what you do there.
Sure. I got extremely lucky because I had a clinical affiliation at NYPH. And first I was on the burn unit, which was fascinating and so challenging.
Doing physical therapy.
Correct.
Yeah. Wow.
And then I went to outpatient, and again, all of my clinical instructors, my mentors were incredible.
Yeah.
So not just for learning and the knowledge of it, but the passion. And so luckily one of them was also into pelvic health. So we went to our course learning internal work together on each other.
Oh my gosh.
So that was fascinating.
Sure. That's, that's a whole other level.
Yes, it is. Brought us closer.
It must have. So us putting on makeup in the bathroom together is like nothing compared to the work you did.
Totally easy.
Yeah. Okay.
But so as I grew in my physical therapy career, I also grew in, again, the pelvic health world a little bit.
Yeah.
As far as the knowledge and treating different populations.
Yeah.
But one of the things I love about NYP is we get to treat a variety of clients.
Yeah, you do.
So yes, it's heavily pelvic health related, but it's also orthopedic.
Oh, it is? You know, my son just called and I said, we're here and we're about to talk about pelvic floor. And you said, it's for men too.
It's for all genders.
See?
Yeah.
And so all genders, and I know we'll get into age, but it's
all ages.
All ages.
Yes.
Right.
There is pelvic health therapy for kiddos.
Mm-hmm.
I don't practice pediatrics, but it does exist
It's real.
as well.
Yeah, it's a real thing.
For sure.
So it's not to be dismissed if your child is bedwetting or
Exactly.
they're definitely not doing it on purpose.
Yes.
Like this is not an acting out thing.
Side note, definitely address constipation if they're bedwetting, but many other influences. So
all sorts of, because constipation is part of it too.
For sure.
All right, we're going there. So, okay, I'm just going to ask you now, what exactly is pelvic floor dysfunction?
Absolutely.
You said there were 4 things, right?
Amongst perhaps some others, but for major things. So we're thinking urinary dysfunction, bowel dysfunction, any kind of sexual issues, and pelvic organ prolapse, pelvic pain.
Yeah.
So those are the major highlights, but what that means is essentially you don't have the best coordination or connection to your pelvic floor muscles.
Got it.
And so that can be one of the issues when people are having difficulty controlling their urine, whether it's leakage or retention, or even urgency without leakage, which
we all have.
Chat for sure.
Oh my gosh, we can all relate to that.
Yes.
Do you see like one of more thing than others?
Yeah. So typically I believe doctors refer a little bit more for incontinence. And having said that, once we start the conversation, more likely than not, people are suffering from other things, issues at the same time.
Right.
So we're really addressing all of it.
You see that as a commonality, like, okay, I'm a woman and I'm coming in because maybe I've had three kids and I now kind of pee all the time, but then you find out, oh, well, she's having some sexual dysfunction because there's pain there. There's pelvic pain. She's constipated, like that.
Absolutely.
Is there generally more than one? Like it's not a solo thing.
Typically, yes. Yeah, okay. And that's, again, we'll go there, but that's because the pelvic floor muscles have several different functions.
Got it.
So chances are if they're having a little bit of a tough time with one, they might have a tough time with some of the other functions as well.
Poor little pelvic floor.
Oh, it's doing its best.
It's doing its best.
Needs a little help.
What causes it?
So many different things. So that's part of why I think going to a pelvic PT is so important, because it's very common, but different people have different life issues or histories or traumas, big T, little t traumas
bring
them into this.
Right.
I was just reading a research study that women were watching video with a little bit of traumatic events, someone getting hurt. Oh. And with EMG, they noticed that their pelvic floor muscles were getting tight as a response to it.
Was it an assault? Were they watching an assault?
Not necessarily. Okay. So there were 4 different scenarios. One of them was sexually related. The others were not. But that goes to show you're sitting in a comfortable place. You know you're safe.
Yeah.
You're just watching something that you know is not real. You know it's a video.
Right. And
your pelvic floor still responds with that tension.
With the tightening or the whatever goes on.
Exactly. Right. So
fascinating.
To respond to your question as far as what causes some of these issues, some of it could just be self-protection mode from whatever happened or whatever we anticipate happening.
Yeah.
Or even just observing what's going on in the world.
Oh my God.
Right.
That leaves us with so much to think about, really, doesn't it?
Yeah. And that's why it's so important to be aware of it so we can change it in the moment.
Awareness is key, isn't it? I mean, it keeps coming back to that. It's just like being aware of things and understanding how your body feels.
Yes.
Right? In certain instances.
Picking up on it, knowing what to do about it. So some of the other issues that I see is people coming in after surgeries, and that could be recent surgeries, or it could be surgeries from 40 years ago.
Really?
And as the body changes, especially with hormonal changes, it was doing its best to kind of pick up the slack. And now it's like, all right, enough.
Can't do it anymore.
I need a little help.
Yeah. With all those hormones gone, like it's bereft.
Right.
It's alone.
Yep. So it's pretty resilient. It can do what it needs to do, but sometimes there's better ways to do it.
To help it out.
Make it easier.
Well, that's the thing that I find so fascinating about all of our all these wonderful conversations we've been having is the consistency around the body, being all intertwined, and that it just, the only constant is change. It's always changing. So being aware of things that we can think about, is helpful to us. So what about I think you said that it is more common in women than men. Is that right?
Yes. Part of it is the anatomy, the length of our urethra, the pressures. The pelvis itself has a slightly different bony anatomy. Okay. So we are meant to bear children, whether we plan on it, we don't. Right. That's a whole other social conversation. Yeah. But anatomically,
that's how we're built, right?
Typically, women are. Again, there's different anatomies, there's different body types. So we really don't want to genderize it. Yep. But when you're learning anatomy, they literally put up 2 different pelvises, and we can see that the female pelvis is a little bit more open. The male pelvis is a little bit more narrow. Right. And so that does change how we function.
The anatomy. I mean, literally of how things all fit together. Are there like stats around numbers of women that this happens to?
Absolutely, yeah. I actually just read the most recent stat that said urinary incontinence the prevalence is 61%.
Wow.
So over half of women in the U.S.
have some sort of pelvic...
Of urinary incontinence. Yes.
Wow, okay.
And then as far as pelvic floor dysfunction, I believe it said 1 in 3 women at some point in their life will have it.
Girls, no one's alone here.
Absolutely.
No one's alone here. Yeah. Right? That's actually like somewhat comforting to know.
For sure.
It's just how we're made.
We're in good company.
It's just how we're made.
And it doesn't mean that it's normal and we need to put up with it.
And then again, you said age, it's pretty much runs the gamut, but is there a sort of a norm?
Yes. So we do see that as we age, we do see increased prevalence of pelvic floor dysfunction and incontinence specifically. So it's the second leading cause of admissions to nursing homes, which is wild to me.
Blows my mind that somebody would get put into a nursing home because of incontinence.
Exactly. So
it seems like insensitive.
Yes. And it's also because, people are rushing to the bathroom because of that urgency incontinence. They end up falling, breaking a hip.
Back. Yeah, I take it back. I didn't have the full picture. Yeah. I get it. Aw.
Yeah. God. And that's why it's so important to address it, because it's not just about incontinence. Because I do have some clients that say well, I leak once in a while. I wear a pad. I do everything I need to do. It's fine. But then we link it to their posture. We link it to balance, and they're starting to see the big picture. So yes, again, you can get away with things and do what you have to do. Right. But why not address it to get ahead of other sequelae that can be more related to mortality and morbidity?
Oh my God, yes. That is, wait, you said you link it to
posture and balance.
And balance.
Yeah.
Incontinence. How come?
Yeah. So there were studies that show that women who are continent tend to sit in a more neutral posture, so lordotic. Yeah. Meaning there's a natural curve in our lower back, so it's not flat. Right. That's what helps to attenuate shock and create better function. Okay. Women with prolapse, which we'll touch upon, or incontinence tend to sit in a little bit more of a slump position.
Oh. Because of how they feel physically, emotionally, both? What?
Well, it's the chicken or the egg. Right. Or is it if you're used to sitting in a slouched position, you're creating more pressure on the nerves that tell those muscles what to do? Oh, my goodness. And those muscles are not in their optimal alignment. Right. So then you end up with incontinence as a sequelae of that posture.
Got it.
So...
Well, I don't know what sequelae is.
Oh, I'm so sorry. Just as a result.
A result. Okay.
Yes.
Good. I'm learning all these words. I'm learning a lot of business words too, because we have some people, I know we have some really great people in our company now too, who have language that I just don't know.
I'm looking things up all the time.
Lingo, and it's cool. I'm like, can you explain that to me? Because I don't know that word. So back to incontinence. Yes. Can you just walk through what exactly that is?
Absolutely.
Yeah.
So by definition, incontinence is your inability to hold in urine or stool or gas when you don't intend to let it go.
So if you're a big farter, that's
incontinence.
You have gaseous incontinence.
Correct.
That can be.
As long as you don't mean to be a big farter.
Right. Well, I don't think anybody means to be a big farter.
I don't judge.
Yeah, I don't judge either.
Yes.
No.
But you're right. Most people don't.
I do. I don't know.
Yes.
Okay.
So point being is that ideally our body is listening to us when we're asking it to do something.
Yep.
And if that's not happening, that can be quite distressing.
Yeah.
So
It
we're
is.
there to really address it.
Right? That's great.
Yeah. And there's definitely further breakdown. So this goes to full evaluation for PT because for people who leak urine, it could be for many different reasons.
Yeah.
So the major overarching themes are stress incontinence, which is more related to pressures.
Okay.
So if we're coughing or sneezing or bearing down as we're lifting something heavy or our kid, we can leak. There's a whole different type of incontinence that's related to urgency.
Okay.
Where the mechanism and the treatment is going to be quite different.
Oh, interesting.
So that key in a door symptom,
Yeah.
where you're almost home, you were absolutely fine for 2 hours walking in Central Park.
Mm-hmm.
And then as soon as you get to the door, you're leaking.
Interesting.
So that's more of an urgency.
Is that like your body at that moment knowing it's close to being where it could be? Or what is that?
Yeah. So a huge component of it is having that trigger. So for some people, it's the key in a door. For others, it's flowing water.
Oh, right.
So washing dishes is a big thing.
Isn't that
so
interesting?
Yeah, this is going a little bit more into brain science, but our brain tends to kind of couple things.
Yeah.
So it creates these neurotags.
That's Pavlov's dog.
That's part of it.
Yeah. Right.
But it kind of puts things together. So this is the environment, or this is the time. This is the sound I hear. Mm-hmm. This is the output of urgency.
Man, it's fascinating, isn't it? Our body is just fascinating.
It really
in
is.
conjunction with our mind.
Yes.
And you mentioned too the like pregnancy, of course.
Yep.
Pregnancy, athletes, people never been pregnant. I guess the prevalence, I guess we had been talking about at one point, that there are different genres of people who become incontinent.
Yes. So I think the important highlight is, yes, in pregnancy, a lot of people do experience incontinence. It's very common. So if you've had multiple births, it's 85%.
Wow.
The question is, a few weeks later, is it still there?
Mm-hmm.
So we know for a good 44% or so, it does persist, and it does require specific attention to it. So having said that, there's plenty of folks who've never been pregnant and who can also experience incontinence and dysfunction.
Yes.
So it's not just about being pregnant or delivering.
No. But that is
that is a risk factor.
A risk factor. Yeah. You mentioned a whole bunch of things about what causes it and why does it increase so dramatically, like at 65, like weakness of muscles.
Absolutely. Yeah. So just like anywhere else in the body, if we are not exercising, if we're not giving our body what it needs, there is a little bit of a decrease in our strength, endurance, anywhere, including the pelvic floor. So the idea is, how are we doing with estrogen? Because that's a huge component.
God,
how are we
question.
doing with strengthening, even hydration, things like fibroids, constipation, which we'll touch upon.
Yeah.
So as we age, we also have a little decreased sense of thirst and a little slower transit through the GI system.
Interesting.
So people do experience a little bit more constipation, and that's actually one of the causes for incontinence, urinary incontinence.
Urine is constipation.
Correct. So
I guess that makes sense. I get that.
Back to the estrogen, there's also recent studies that show people might have urinary urgency and incontinence purely related to the decreased estrogenation of the area.
I believe it.
So when people got estrogen cream, that helped their symptoms.
Oh, that's cool.
It is. I will say that's definitely outside of my scope as a physical therapist.
Yeah.
I just want to make sure the word is out there.
Yeah.
But it's really important to speak with your doctor. Make sure it's appropriate. Obviously, there's some populations it may not be.
Right.
We have more and more research to show it is actually safe for more people than we thought it was before.
Yes, agreed. We're doing actually, you and I'll tell you about this later, but I'm having an in-person Inside the Wellspace in September live with Chitty.
Oh, yes.
Yep. A doctor called Chris Creatora, who was on here as well. You know Chris,
I know
right?
her, yep.
Right. And they're talking about, from both of their fabulous perspectives, hormones.
Estrogen. Yeah.
All of it.
All of it.
All of it. So I'm going to bring this up. You should come, actually. Pelvic organ prolapse.
Yes.
What is that?
So essentially we have our uterus, our bladder, our rectum, the intestines. They're all supported by the pelvic floor and the fascia in the pelvis.
Okay.
So for different reasons, for a lot of folks, it's because of pressure management.
Yep.
So if you're pushing or straining to go to the bathroom or lifting heavy with suboptimal technique, that creates pressure down. And if the pelvic floor can't sustain that, then you have a bit of a descent of any of those organs.
Right.
So it definitely doesn't mean that your uterus is going for a walk outside of your pelvis.
Oh my God.
But
That's
it does
scary.
mean there's a little bit of laxity in the wall of the vagina.
Right.
And
So it like falls.
I wouldn't use the word falls. I would just say
use the
that
word.
there's a little bit of a descent.
Okay.
So people might notice it's more difficult to empty their bladder because of that.
Right.
Or they're having pain with intercourse,
Yeah.
specifically with deep penetration.
Okay.
That would be a sign of that prolapse.
Got it.
Or they're doing fine, and then as soon as they stand up after urination, they notice a few drops on the toilet seat.
Oh, yeah.
That could also be a sign of uterine or bladder prolapse.
Okay.
More likely bladder.
That's good to know. That's an interesting one right there, is if like you've already gone to the bathroom and then you get up and there's still some little droppies.
Yeah.
Like, what's that?
Yeah.
Okay.
So essentially our bladder is sitting in the pelvis and there's the urethra, the tube, right? Mm-hmm. So if there's a little kink in that tube, because the bladder is sitting a little bit lower, not all of it can come out. There's a little pooling of the urine.
Right.
And when you stand up, it's essentially straightening of that tube.
Right.
So then those couple of drops come out.
Wow. Good.
Right.
That's so helpful to know.
Right.
That's a little FYI.
It is.
FYI, you got to go get this checked out.
And there's definitely things we can do to help empty it better or support the organs better.
Yeah. Mm-hmm. You mentioned something about UTIs as well. What's up with that?
Yeah. So part of our pelvic floor function is being able to have everything where it belongs. So being closed vestibule at rest.
Okay.
And vestibule being the outer portion of the vaginal canal.
Okay.
So the entrance to the vaginal canal.
Okay.
And so if there's too much tension in the pelvic floor muscles or your inner thighs, or if there's decreased lubrication, so you're not getting that complete closure.
Which of course happens to all of us as we go through menopause and lose every hormone in our body. Yes.
Decreased for sure. Yes. Or again, if there's a little bit of prolapse or a little bit of a descent of the urethra, so it's actually closer to the opening, then we have more chance of bacteria coming through.
Got it.
It also has to do with pH. There's multiple components which could predispose you to UTI.
Yeah, that's good to know though too, especially as, if you've got the prolapse happening and, those factors are there. It's good to know that UTIs could be a result of that.
Absolutely.
And then that's note to self, like, I actually have a friend who just got a UTI, so maybe I'm going to talk to her about this. So are there things that women can do to bolster the pelvic floor as we get older?
Absolutely.
Like what?
So I would say just awareness is the primary key.
Yeah.
It's tough to give a blanket statement advice because for some people, it's actually too much tension that's creating gapping or pain or incontinence. For others, it's just a little more loose, right?
Yeah, yeah.
So either way, whether it's tight or opposite, it might be weak.
Right.
So I think it's a common misconception where if something is tight, that means it's strong, it's good. Opposite. So depending on what your body actually needs, that's what drives the treatment.
Right. It's like anything, isn't it? Right? There's no one size fits all. You really have to speak to your doctor and address it and figure out what the heck is going on.
Exactly. But yes, to answer your question, there are things we can do, which is our breath work, which again, we can touch upon in a moment.
Okay.
Making sure that we're hydrating well.
Yep.
So what people often end up doing is if they're noticing incontinence, they tend to stop drinking water.
Oh.
And that actually
funny.
That
seems, but that's funny. Huh. Okay.
That's what I often see. So if people are saying like, well, I don't want to leak, I don't want to produce urine, so I'm going to stop drinking.
Got it.
Your kidneys are still producing urine. It's just more concentrated, and then it becomes more of an irritant to the lining of the bladder.
All right. So the bottom line is don't stop drinking water.
Exactly.
Even if you're incontinent.
Yes.
Okay.
Especially.
See, especially. So that's good.
Now, we want to make sure we're sipping on the water. Yes. Yeah. So we don't want to gulp it. And there's definitely ways that we can manage the timing of it better, but for sure drinking water. Making sure you're paying attention to your body and you're honoring your pelvic floor muscles just like you would the rest of the muscles.
Right? You have to think about it.
Yeah. Meaning strengthening, stretching, all of the things.
You know, there's so much talk now and focus on gals as we get older about muscle building and muscle training and strength training. We must incorporate into our arms and core
pelvic floor.
Our pelvic floor.
Well, pelvic floor being the bottom of your core.
The bottom of your core. And
that
it's the first chakra in your body, by the way.
Exactly. Yes.
So you know that, don't you?
I am a yoga therapist as well.
Oh my gosh. Yeah. Wait, I love this. This is so good. Can we do a show and tell? Because I'm like staring at your thing down there and all these things you're saying, I'm like, I want to see what that is.
I keep saying pelvic floor muscles, but here they are.
Here they are.
So
show
this
our
is
friends.
Our pelvis.
Yeah.
So if we put our hands on our hips, essentially we're putting the hands on this iliac crest area. And then if we're looking from the back, this is the spine.
Okay.
Terminating in a tailbone.
A little bit more. Okay. Yep. Okay. That's the spine. Great.
So right through here.
Uh-huh.
If we're looking from the front, that's our pubic bone.
Okay.
And so the pelvic floor muscles are all of these guys in red that span from the pubic bone back to the tailbone.
Those are the muscles.
Yep. And in between the sit bones.
Gotcha.
So it's essentially this hammock that supports our organs, which are here. So that's our bladder, our uterus, and the rectum. Bladder's in the front.
It's the big one. Bigger.
If it's full, it will be bigger.
Okay.
If it's not necessarily.
So okay.
Yeah. The uterus that's behind and sometimes a little bit more on top of the bladder.
Okay.
So that's why when we are pregnant, there's definitely more pressure on the bladder.
Boy, do you have to pee. Yeah.
The kiddo is literally doing a jig.
Oh, yeah.
Perhaps not literally, but sitting on top of the
mine
bladder.
Did. Mine were busy. Yeah.
I tend to do that.
Okay.
And behind that is the rectum.
Okay.
Right.
Also, which also gets a workout when you're pregnant because with the baby kicking and moving, it's all, so that actually, this visual is really helpful to understand
the relationship.
Sweet. And then there are the fallopian tubes and your ovaries and
fallopian tubes, and ovaries. Absolutely.
Yep. Oh, that's so pretty.
So back to the pelvic floor muscles. There's essentially 3 different layers and they have slightly different functions.
Okay.
So I mentioned the introitus here. So we have our vulva, which is kind of like our face.
Okay.
The vagina is going to be the mouth.
Yep.
And you can think of the introitus as that opening to the vaginal canal.
Okay.
So the pelvic floor muscles help to keep this closed at rest. And then if they're too tight, obviously it's going to be painful to create opening.
Right.
So whether it's a gynecological exam or a tampon or a partner or a toy.
Yep.
That's going to affect it.
Gotcha.
Right?
Yep.
That first layer also goes around the anal opening as well.
Got it.
So if we're talking fecal incontinence or constipation, we need to address that.
Got it. So the muscles are worked, I guess. You do work with the muscles to open them up, make them stronger, fortify them, all of the above?
Yeah. So number 1 is the coordination.
Okay.
So our ability to get in touch with those muscles and for them to follow your cue.
Got it.
And yes, getting strength, getting flexibility, being able to get them to do what you want them to do.
Okay.
And there's 3 different layers. So that's the first. The second goes more around the urethra. And the third is the deepest layer. So we'll do a little mini hysterectomy here. Sorry.
Oh my goodness.
Bad PT humor. So the third layer, the deepest layer, is the one that runs from that pubic bone all the way around to the tailbone.
Oh, wow. Yeah, I see that.
And that's the layer that creates the most support.
Okay. Oh, okay. Got it.
And so far, we've really highlighted the pelvic floor function when it comes to urine, bowel movements, sexual function.
Yep.
It also works like a sump pump. So as it contracts and releases, it helps to get rid of any edema or swelling or any lymphatics that otherwise stay stagnant.
Oh.
And it's like we said, the bottom of the core.
Right.
So it helps to transfer the load from the leg to the pelvis and from the torso to the leg when you're upright and walking.
From a lymphatic drainage standpoint, is that what you mean?
So yes, but also from the musculoskeletal standpoint.
Oh, okay.
So if you're thinking of your two legs,
Yep.
they meet in the pelvis.
Yep.
The thing that supports the two hemipelvises together is the pelvic floor.
Is the pelvic floor. So the pelvic
Yes.
floor is really an unsung hero of the body.
It's like the keystone.
It really is.
Yes.
We really need to pay attention.
Absolutely.
I had a friend, she used to always say, faites attention, Catherine,
Oui.
which means pay attention, Kathy. So,
Oui.
and I would say that to my kids when they were growing up, when they were like, not, I'd be like, faites attention. So the pelvic floor needs that.
This is it.
Right.
And I also want to highlight the fact that it intimately works together with this guy, which is your obturator internus, which is a hip muscle.
Oh, cool. Oh.
As well as the piriformis in the back.
Huh.
So meaning it doesn't function in isolation.
Right.
And that's why it's so important to look at the whole body.
Yeah.
So,
Well, you know, what's interesting that what you just said about hip too is that women in menopause, perimenopause and postmenopause, we very often get hip issues.
absolutely.
And that is attributed in part to the decline of the hormones that we have. But maybe this is
Absolutely.
part of it with the changing of the hip muscle situation that goes on in the pelvic floor.
Absolutely.
Oh my gosh.
So that's why hormones are so important. And that's why we look at the hips, not just the pelvic floor itself. And we also want to look at the nerves that are here.
Yeah.
We want to look at the vasculature. So again, yes, pelvic floor muscles is the highlight of the show,
Yep.
but we're also looking at all the other components,
Yep.
the fascia, all of it.
That's a lot.
Yes.
It's a lot to know.
It's a lot of ways to make people better or help people get better.
You're very good. You're a very good person. Breathing, you mentioned.
Yes.
You mentioned breathing, and it can play a role in your pelvic floor.
A huge role.
Let's hear about it.
What we often find is folks have more urinary urgency or more issues when they're breathing in their chest. And sometimes we call it paradoxical breathing.
Okay.
Yes.
Now I'm breathing consciously. Yes.
So just as a super quick overview,
Yes.
what we notice is there's more pelvic floor tension and decreased coordination
Okay.
if we're taking a breath into the chest
Yeah.
while tightening the belly, the pelvic floor,
Yeah.
the rib cage. So that often happens if we're stressed or if we're rushing, if we never take a pause to let go.
Right.
And so over time, that can become our automatic breathing pattern.
Yes. And us type A people in New York City tend to do that a lot. don't we?
Constantly go, go, go.
Yeah.
For sure.
Yeah.
So one of the things that we assess and address from the get-go is the breath pattern.
That's smart
Yeah,
because it's all related.
exactly. So ideally, the diaphragm works together with the pelvic floor like a piston.
Right.
So when we're inhaling,
Right.
the diaphragm goes down, the rib cage expands, the belly gently expands.
Yeah.
So does the pelvic floor.
Interesting.
If we never take a full breath in and out, the pelvic floor never gets a chance to let go fully.
To just expand. See, it's fascinating that we really do need to be mindful of how we're operating our bodies. You know,
Absolutely.
we just do. We just do.
Yeah. And a huge component of that is the nervous system too.
Is the nervous system because it connects it all.
Absolutely.
Fascinating.
That's the driver.
Can you explain the symptoms of I know it's like PFD, which is pelvic floor
Pelvic floor
dysfunction.
dysfunction.
But what is the dysfunction and what are the symptoms that those of us who might, what should we be looking for?
Yeah. So the pelvic floor dysfunction is decreased ability for those pelvic floor muscles to hear you when you're saying contract or let go.
Yep.
So we know that at least a third of women tend to valsalva or to strain
Okay.
when we're actually asking for that Kegel or contraction. So they're actually doing the opposite.
The opposite.
So that's pelvic floor dysfunction.
Got it. Oh.
Or if it's folks who are unable to let go completely, if it stays tight.
Yep.
Right. So you just don't have full control.
Right.
And those symptoms could be urinary incontinence or retention.
Yep.
They could be constipation
Yep.
or fecal incontinence, pain. So whether it's just pain at rest with any kind of activity or pain with intercourse.
Yeah. All this
All of the
stuff.
Yep. And pelvic organ prolapse.
What are the contributing factors to all of this dysfunction that we should be thinking about as we go into our day-to-day?
Absolutely. Yeah. So I would say constipation.
Yeah.
And what you're doing as far as hydration, what you're eating, how you're eating. So we could be eating super healthy, but if we're chowing it down super quick as we're running between meetings.
Which a lot of us do. I mean, moms do that because, you're running from here to there. Working people do it. We do
what we have to do.
We do what we have to do.
Taking that pause is important. Yeah.
We are super women. We are super people.
Absolutely.
We girls. We really are. It's one thing after another. So
I would say constipation is a big part of it.
Yep.
Nervous system.
Yep.
So again, if we're constantly stressed, running around, worrying about things and not giving ourselves a moment to let go.
Yep.
That can lead to that tension and pelvic floor dysfunction.
Yep.
Surgical history. So for folks who delivered via cesarean section, some people are pretty resilient and bounces back, but for most, they do need a little bit of TLC to that scar.
Yes.
And the underlying tissues.
Interesting.
Yeah. There's also fibroids that we need to be aware of.
Oh, right. Interesting. Yep.
Pressure management.
Yep. You said some medications could impact.
Absolutely. Yeah. So things like diuretics, there's so many women who have heart disease. We know that's the leading cause, right? So people take medication for that.
Yep.
People take thyroid medication.
Yep.
All of that impacts how our body functions.
Yes.
There's some people who are on lithium for their mental health.
Yep.
And then they have to drink more water. They will be dehydrated.
Interesting. Yep.
So that impacts, again, their bladder health.
That it does. Does it make it better or worse if you drink too much?
They have to move through more fluid.
Gotcha.
So they're going to have to go to the bathroom more frequently.
Yeah. Other things too, you said high impact exercise.
Absolutely.
Which is interesting.
So it can be a driver for dysfunction. It doesn't have to be.
Right.
So if you're training your pelvic floor muscles and the pressure management of your body to react to that load, great.
Yep.
But if you're not, it does create pressure down.
Just be aware is what we're saying here.
Yes.
Just be aware.
By the same token, I would say even your foot mobility and position impacts it. So if your feet are overpronated, for instance, they're not absorbing shock as well. So if you're trying to run on that lack of absorption, that shock has to go somewhere. So the pelvic floor is the next stopping place. Now, again, it doesn't mean that it's all over, but when we're seeing pelvic floor dysfunction that's specific to during running, we're definitely looking, top to bottom. So we're looking at the foot.
But these are really great questions that when you're looking for your doctor and you're going to talk to your doctor, these are the questions that need to be asked.
Absolutely.
Right? To find, people should be so lucky to find somebody to work with like you that ask these things.
Thank you for saying that. But hopefully all pelvic PTs are looking, again, at the pelvic floor specifically, but also outside of it at the whole body, whole person.
Yes. Speaking of the whole, I'm just going to touch on some other things that you had mentioned, which I think are important just for people to be aware of. We talked about posture and incontinence a little bit, right?
Yeah.
Balance and incontinence, back pain. What about all of that and incontinence?
Absolutely. So back pain and back function can definitely be a driver for incontinence as well. Okay. So if we think about it, all of the muscles in our body work because they're innervated by the nerves. Right. And all of our nerves originate in the spine.
Right.
So if we're having a dysfunction in the spine, whether it's decreased mobility or disc herniations or stenosis, so narrowing of the canals, that impacts what signals the nerves can send to our muscles.
Okay.
Part of it is the muscle function. Part of it is the nerves also send information to our bladder and our bowel.
Yeah.
So they might be telling the bladder to give us a signal of urgency when it's not actually full. So that's why we also look at spinal mobility and function when someone presents with pelvic floor dysfunction.
Okay. Quick questions too. What exactly is a prolapse?
The prolapse is that descent of the organs, whether it's uterus, whether it's bladder or rectum.
Right.
And so there's a weakening in the wall of the vagina or the connective tissue.
So that red muscle that we saw down there or
or
facet
the
of it,
actual
piece of it.
walls of the vagina that are higher up.
Okay, got it.
So it's almost like a pouch that goes into the vaginal wall.
Okay.
That's coming down from either the top, the uterus, a little bit more from the front, the bladder, or the back of the rectum. And part of it is genetic for sure, as far as our connective tissue.
Yep.
But part of it is our pressure management.
There you go. Managing the pressure of the pelvic system.
The actual physical managing the pressure, but also managing the pressures of life.
Exactly. Right?
Yeah.
I mean, well, sure, something's got to give. So what are types of bowel incontinence?
Sure.
Because it affects a lot.
Yes. So again, with bowel incontinence, we have fecal incontinence with the actual stool. We have gas incontinence. Yeah. So those are the majority, like the highlights of them.
But okay, can we just, for all of us who are walkers and just get gassy when we walk, is that incontinence or is that just walking and gas coming out?
So we say mobility equals motility. Which means that the more your body is moving, the more you're facilitating peristalsis, so the movement through your GI system.
Okay, is that a good thing?
So it's good to get things moving, get things out.
Okay.
So chances are there was already a bit of gas there, but as you're moving, you're actually facilitating it getting out.
But
so
it doesn't
that's not
mean
a
that
bad
you
thing.
have gaseous incontinence, because
Incontinence only means that you can't control it when you want to.
Okay. As a walker, and with the gas coming out sometimes, I just want to make sure that this is not a bigger issue that I need to be thinking about. So, it happens sometimes, not all the time, but it happens.
Well, that leads
And then
me
I say,
to...
excuse me.
Perfect. And that's all you have to do. But that leads me to ask the question of, is there too much gas buildup to the point where there's distension and there's discomfort?
Oh.
Or is it just that you have a normal amount of gas that comes out during that time as opposed to when you're in the bathroom?
I think probably number two, the second one. But that's a good question, and that's good for us to be thinking about, because so from a gas perspective, because we're all gassy, if it's uncomfortable and you're distended, that's something you should be thinking about.
Yes, or if you can't get it out.
Oh.
Honestly, I'm more worried about folks who it's just sitting there, because then it can,
painful, right?
It's painful, and it can also interfere with the actual bowel movement moving its way through.
Interesting.
Again, there's definitely things we can do as physical therapists to address that.
That's good. Okay, good. And you mentioned hemorrhoids and a rectal prolapse. What's that?
So rectal prolapse is when you have a bit of that descent, but instead of through the vaginal wall, that descent is through the rectum itself.
Got it.
So the anal canal.
Got it.
Yep. But same idea, where you have suboptimal support up and perhaps too much pressure down. So folks who are used to straining to have a bowel movement, one of the possibilities is that prolapse. What can we do to help ourselves with all of this? Like, what are some of the practical tools that we can do if we're recognizing symptoms, et cetera? Absolutely. So I will say the number one thing is, again, it's individualized.
Yep.
So optimize your diet, optimize your hydration, see if you can make sure you're moving and breathing.
Yep.
So if we're sitting for a prolonged period of time, at the very least, let's make sure we're sitting with appropriate position and posture, but then do try to stand up and move. So that way you're not getting those pressures and that stiffness. Physical
therapy, obviously, is really the answer.
Yes. And I recognize I'm biased because I am a physical therapist. So as long as you see a doctor and you're ruling out any serious pathologies, if you're concerned or if your symptoms may warrant it, I think physical therapy is the answer, because we can actually assess and see where things are coming from and what are your individual drivers,
and
because they might be different.
Practical exercises. So what does PT treatment look like? Because it's nerve-wracking, I think, for, because it's also intimate.
The first portion of a physical therapy evaluation is talking. So we're getting the subjective intake to figure out, okay, this is the reason why you're coming in. So for instance, incontinence, but what else is going on in your life? What is the history as far as your surgeries? Have you had pregnancies, deliveries? Have you had any other issues as far as just trauma history? And I will say, ideally, we're treating everyone with the trauma-informed care. So I don't need to ascertain whether or not there was a big T trauma.
Right.
I'm going to just honor you as a person and
Beautiful.
respond to how you're presenting.
Beautiful.
Right?
Beautiful.
That's a whole separate conversation.
Yeah.
But yeah, so we really want to understand what your symptoms are and what could be the possible drivers already, just based on what you're telling us your history is.
Yeah.
And then we can get a little bit more specific with our objective evaluation. So again, yes, we look at the pelvic floor, but first we're looking at the posture, your spinal mobility. We're looking at the strength of your hips, since those guys are the anchors.
Which
essentially
we've seen.
Environment. Yes.
See, this is good because now that we've talked about it all and we've seen it, we can understand what you're saying. That's great.
Yes.
Okay. So you look at the hips.
We look at the hips, depending again on if you're telling me that you're only leaking when you're running or walking, I'm going to do more specific evaluation of your foot mechanics, things like that.
Amazing.
Right?
Yep.
It's wonderful. And then we also want to look at your abdomen. So whether or not you've had a history of surgeries or a history of constipation, then for sure I want to look at that sooner rather than later. But in general, I want to see if there's any restrictions. So many of us were taught to kind of hold our stomach in to look good, to fit in the dress.
God, aren't we? Still.
But yes, that impacts our pelvic floor and our breath. So if we're not allowing our stomach to expand, that breath is going to come into our chest. And again, that's what can lead down that paradoxical breath. Right. So
for us, my gosh, sorry, I don't mean to be a downer for us, but like that's a lot of direction we've had on how to manipulate our bodies, and it's not good. It's not good for us.
And we're not even going into the whole being a good girl, holding emotions in, which can absolutely create more tension.
Oh, of course.
We store a lot of tension in our hips and our pelvis just based on that.
Yep, we sure do.
That's a whole other story.
I know. You need to come back.
I mean, I have a lot of other stories that we can focus on.
I know. I feel like when we were talking before, I could have gone in so many different directions with you because you are a wealth of information.
I appreciate that, but our body is a wealth of knowledge and background. So I do want to finish the whole evaluation with the crux of it, which is the pelvic floor evaluation. And I kind of say that, it's a physical therapy evaluation bus. I leave it up to my clients to tell me which stop they want to get off at.
Good.
So yes, in order to get the most efficiency in the evaluation and treatment, we do want to look at the pelvic floor muscles directly. So that means looking externally. So we would have the client undress, cover with a sheet, and then in a modest way, being able to see what is their vulva looking like, what is the skin looking like, is there suppleness, estrogen or not? Are there other things dermatologically that can be creating their irritation or urgency? We're not diagnosing it, but we know to refer to the appropriate practitioner to address it. So things like lichen sclerosis, things like that, which we can discuss at a later point. But that can also create pain and urinary issues, right? So from the outside, we're looking at coordination. So can you contract? Can you release? When you're coughing, what does your body automatically respond with? Is there tension in the surrounding tissues, like your inner thighs? And then we look at the 3 pelvic floor layers by doing an internal assessment as well.
Got it.
So we're just using 1 digit, so 1 finger, gloved hand with lubricant. And we're looking to see, again, at all the different layers, is there too much tension? Is there asymmetry? Can you feel our touch? Is there tenderness? And can you, again, coordinate those muscles in the way that you would like to? And so, again, I'm kind of highlighting the muscle layers, but we're looking at connective tissue. We're looking at bony anatomy. We're looking at nerves and ligaments. So it's a vast evaluation.
Yeah, it really is.
And going back to that bus idea, I don't want it to be a stopping point for folks who have grown up with this notion of that area being taboo. Right. So we may not get to the driver right away, but there's still other things that we can just get the ball rolling with that can hopefully be helpful.
That's great. That is good, because it could also just be a process, of getting comfortable with it and trying to figure it out. And, like everything we do, we are doing here with us, with our conversations. And I can't believe we've been talking for an hour already. There's a lot to know.
Yes, there is.
So as we sort of wind down and finish up, is there anything you want to leave people with, just sort of top line?
Again, number one, you want to get an evaluation. So it's very specific treatment to what the issues you face.
Yeah.
Right?
Yeah.
But number two, you just want to check in. So throughout the day, just take a little check-in, take a pause and notice, are you holding intention? Where are you breathing from? Can you let go of anything that you don't need within your body, within your environment? As far as urination is concerned, again, definitely addressing constipation if that's an issue, which we can talk for another hour and a half about constipation. Okay. But that's definitely a driver. Making sure that you're not power peeing. Yeah. So not forcing it out because it literally takes 20 to 30 seconds to urinate, ideally. Yeah. And it's not going to change anything outside of the door, even if your toddler is screaming. No. I know they tend to ramp up, but those 20 seconds won't make a huge difference.
But give yourself the time is what
Give yourself the time to actually do what your body needs to do.
Pay attention.
Yeah. So just honoring your body and yourself.
Kate.
Yes.
You're amazing. Amazing. And this does really say there is so much more to talk about. So
absolutely.
I'd love to have you come back and share more with us.
I would love that.
Thank you.
And I really appreciate the opportunity to just get the word out there.
Thanks.
Yeah.
All right. We'll see you again.
Thank you so much.
Pleasure. Thank you so much for listening to this episode of Inside the Wellspace. Subscribe now on Apple Podcasts, Spotify, YouTube, or wherever you listen to your podcasts.